My task today is to discuss this clinical meaning of myocardial fibrosis in athletes. So, macroscopic myocardial fibrosis can be detected by contrast-enhanced cardiac magnetic resonance using the late gadolinium enhancement technique. Macroscopic myocardial fibrosis, as evidenced by cardiac magnetic resonance, can be found in inherited cardiomyopathies such as hypertrophic cardiomyopathy or dilated cardiomyopathy, and the presence of myocardial fibrosis provides a substrate for life-threatening ventricular arrhythmias and sudden cardiac death in this condition, and is considered independent predictor of arrhythmic outcome in patients affected by these inherited cardiomyopathies. So an isolated non-ischemic myocardial fibrosis can be detected infrequently in athletes. You can see here that according to most of the published series of cardiac magnetic resonance in apparently healthy athletes, myocardial fibrosis is an uncommon finding, and when present, usually shows a junctional spotty pattern rather than a stria pattern. So there is growing evidence that isolated non-ischemic left ventricular scar can be substrate that conceals clinically silent substrate of life-threatening ventricular arrhythmias and sudden cardiac death in individuals with an apparently normal heart. This is a case of an Italian professional soccer player done suddenly a few years ago. And this was his ECG at the time of pre-participation cardiovascular evaluation, and you can see that is substantially normal, except for a trend towards low voltages in limb leads. And he had, of course, was eligible for competitive sport activity and died suddenly during a game. So the mass media said died due to myocardial infarction. That is the usual cause, reported cause of death. But the autopsy, in Italy we perform autopsy in all cases of sudden cardiac death. The autopsy showed that there was a scar that is not ischemic in nature. In fact, you can see here the histologic examination showed that the scar was confined to the outer layer of the left ventricular wall. If you consider instead ischemic scar, usually is subendocardial or transmural as a pattern. So he died due to an isolated left ventricular scar. So we subsequently reported the clinical characteristics and the arrhythmic outcome of a series of athletes with ventricular arrhythmias and isolated left ventricular scar. This is an example of an athlete with non-ischemic left ventricular scar, subepicardial, located in subepicardial left ventricular wall, and arrhythmias with the right bundle branch morphology and superior axis. The morphology is concordant with the location of the scar that is confined to the lateral, inferolateral wall. And this athlete also had sustained ventricular tachycardia. And we compare the group of athletes with those of athletes with ventricular arrhythmias without late gadolinium enhancement and controls. What is interestingly observed in our study was that the scar is clinically silent, as you can see by the low prevalence of alarming signs and symptoms. You can see here that a minority of these athletes with left ventricular scar had ECG abnormalities in terms of low voltages, of QRS voltage in limb leads, or T-wave inversion in the leads exploring the inferolateral walls of the left ventricle. And the majority instead had a completely normal echocardiogram. Because the scar is confined to the outer layer of the left ventricular wall, it doesn't account for a reduction of contractility or local contractility that can be detected by echocardiography. So what about the outcome of these athletes? You can see here that over a mean follow-up of 3 years, we had a number, 1/4 of these athletes actually had those actually had malignant events such as ventricular tachycardia and also one sudden cardiac death. And you can see here that malignant events was limited to the subgroups of those athletes with ventricular arrhythmias and subepicardial scar in the form of stria. So we also compare athletes with different morphologic pattern of myocardial fibrosis. And you can see here that these are athletes with the stria pattern involving more segments of the left ventricular wall. And these instead are athletes with the spotty junctional pattern of myocardial fibrosis that is confined to the junction between the septum and the free wall of the right ventricle, posteriorly or anteriorly. And you can see here that malignant arrhythmia events were distinctly associated with the stria pattern, while the spotty junctional pattern was associated with the uneventful outcome. So this is an example. The only, fortunately, case of sudden cardiac death was a 39-year-old cyclist. At a pre-participation screening, there was no family history of sudden cardiac death or cardiomyopathies, was completely asymptomatic, and the 24-hour ECG monitoring showed frequent coupled premature ventricular beats with the right bundle branch block morphology, as you can see here, with the superior axis, suggesting the origin from the left ventricle, probably from the inferolateral wall. And this is ECG. Look at ECG. It was normal in terms of repolarization of abnormalities. But once again, there was a trend towards low QRS voltage in limb leads, because the scar reduces the electrical activity of the left ventricular myocardium that translates into voltages of QRS in limb leads. And the echo was completely normal. But the cardiac MRI showed at post-constant sequences epicardial late gadolinium enhancement in the basal inferolateral wall. And this was dismissed as a healed myocarditis, as considered normal. And the athlete was allowed to perform competitive sport activity and died during the game. This is the histology. Look at the histology of the, because we study histology every case. This is very important. You can see here that there is the scar. This is the scar. This is a subepicardial scar. And look at the higher magnificence histologic examination. You can see that the fibrofatty scar replacement is not just fibrous replacement. And very interestingly was that genotyping of these sudden death victims demonstrate a desmosomal digenic heterozygosity for mutation in desmoglein 2 and desmocolin 2 that are genes encoding for desmosomal proteins. These proteins are characteristically defective in arrhythmogenic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy. So this information is consistent with the concept that this scar is a sort of segmental arrhythmogenic cardiomyopathy confined to the left ventricle. And this is confirmed by the family screening showing the same scar in the brother and some abnormalities on the right ventricle in the sister of these sudden cardiac death victims. Both had a single desmosomal mutation affecting the desmocolin gene. So, isolated left ventricular scar in this study from the Lazio region, that is the region of Rome in Italy, so this is not our region, the Veneto region, showed that this scar was the most important cause of sudden cardiac death in young people and athletes, accounting for 24% of fatalities. So it's extremely important, these substrates. So can we enhance our ability to identify this scar in asymptomatic individuals, this clinically silent scar in asymptomatic individuals? We performed this study using 12-lead Holter monitoring, including an exercise session. And you can see here that we found premature ventricular beats, isolated complex or exercise-induced in roughly 10% of athletes, all underwent echocardiography, and the subgroup underwent also cardiac MRI. And you can see here that a positive, abnormal cardiac MRI in terms of left ventricular late gadolinium enhancement was distinctly associated with the premotor ventricular beats with the right bundle branch block morphology. In other words, if you use 12-lead Holter monitoring, including exercise, an exercise session, that you can discover this kind of premotor ventricular beats that are highly predictive of this scar. Some example, you can see here an athlete with left ventricular scar, isolated left ventricular scar, and premotor ventricular beats, complex non-sustained ventricular tachycardia during exercise with right bundle branch block and superior axis, and other athletes with scar, isolated left ventricular scar, and during exercise, isolated premotor ventricular beats with right bundle branch block and superior axis. And the last information I would like to provide you is that this was a paper we just published a few days ago concerning the exercise testing for increasing the sensitivity for these athletes with the scar. And you can see here that athletes with exercise-induced ventricular arrhythmias compare with athletes without exercise-induced with ventricular arrhythmias that were not exercise-induced. You can see the comparison. Athletes with exercise-induced ventricular arrhythmias actually had a higher prevalence of a positive cardiac MRI in terms of ventricular scar compared with those with non-exercise-induced ventricular arrhythmias. And you can see here that exercise-induced ventricular arrhythmias, mostly with the right bundle branch morphology or polymorphic, were independent predictor of a scar, left ventricular scar, with the odds ratio of more than 5. So this is an example of an athlete with exercise-induced premotor ventricular beats with the right bundle branch block and superior axis morphology and the left ventricular scar. So in conclusion, isolated non-ischemic left ventricular gadolinium enhancement with the stria pattern involving more segments of left ventricular wall may be associated with the life-threatening ventricular arrhythmias and sudden cardiac death in the athlete. Because of its subepicardial location, left ventricular scar is often undetected by echocardiography. So in athletes presenting with ventricular arrhythmias with the right bundle branch block morphology, especially exercise-induced, a normal echocardiogram doesn't exclude the presence of an underlying potentially malignant arrhythmogenic substance. The available evidence doesn't support a cause-effect relationship between intense sport training and arrhythmogenic left ventricular scar. Left ventricular late gadolinium enhancement with the junctional sporty pattern instead appears associated with a benign outcome. Thank you for your attention.